All right, good afternoon, everybody. Let me share my screen. All right, are we good? We have, all right, we're good to go. All right, well, welcome everybody. My name is Jay Voigt. I'm with Human Capital Consulting, and today we're going to do a little overview on the new ASAM criteria. So as you heard, the fourth edition recently came out. And so we only have an hour today. This is a short webinar, so I'm going to do my best to give you a kind of brief overview and dig in a little bit to some of the things that'll be pertinent to those on the call. So just super quick about me. I'm about family. I'm about being outside. I've been doing a lot of conferences. My coworker over here usually disrupts my webinar, so but I've been doing this for about 20 years. I'm a substance use disorder guy. I've worked in a ton of different settings, jail, schools, prisons, inpatient, outpatient, residential. And right now what I do as a consultant is I help organizations develop people and leaders in high performing teams. How does that relate to ASAM? Well, let's get into our agenda and we'll show you. So we're going to look at the ASAM criteria specifically as it relates to treatment matching. That's where it seems like there's the most discussion and talk right now. We'll dig into some of the updates and impacts on reimbursement. We're going to have some fun talking about the practical applications about how to improve client care and organizational efficiency. That's not a buzzword. ASAM really can help us with that. So we'll dig in. And then at the end, I'll have some tools and resources. I will send out the slides to everybody on this webinar at the end. So you don't have to worry about taking screenshots or whatever. So I'm gauging the audience's reaction to this next slide. Seeing a little bit of reaction. So what is ASAM? ASAM, it's an organization, right? It's the American Society of Addiction Medicine. But when you hear people talk about ASAM, they're usually referring to the ASAM criteria, right? And so today we're talking about the ASAM criteria. And we're talking about the fourth edition. They define it as a set of guidelines that use holistic, person-centered approach for developing treatment plans for patients with addiction and co-occurring conditions. So times are changing. We're learning more. This is ASAM's current definition of addiction. That's changed a couple times over the years. And on the right side of the slide, the DSM, right? We're on version 5 of the DSM. As we get to know more about treatment, about recovery, about the field, we're getting more information and we're doing our best to integrate it in a way that makes sense. If you're like me, every time a new edition comes out, I get a little jaded because then I got to learn something new and it changes the way I do things. And then I get over it and usually it ends up being a good thing. I'll let you guys be the judge today as to where we're at in terms of progress or not. So let's talk a little bit about treatment matching. Treatment matching has been around for a long, long time. And we used to have pretty limited treatment options, right? There was like inpatient rehab, detox, and outpatient counseling. Over time, that's expanded. We have a lot more services, particularly in the past 10 years, peer recovery support, recovery housing. These are things that are getting more and more attention because they work, they're valid, they're helpful, and they're actually integrated into the criteria, which I think is super cool. It shows me that the medical community is really trying to understand the whole picture and not just through this medical lens. Treatment matching is difficult. So I don't know if you guys have ever seen this quote before, right? But like the way we used to do treatment 20 years ago, you call the treatment center. When can you come in? You get there, you're admitted, right? There wasn't a whole lot of screening sometimes. I once had a patient where the mom packed the woman's bag, brought her and dropped her off in the lobby. Like that was it. Like no conversation, not how are you going to pay for this? Do you have insurance? Mom was convinced this is what needs to happen. And I just want to super quick call out some of our biases. a lot of us in recovery have had different experiences and we've recovered different ways. And we tend to have to favor the way that we recovered, right? So for example, if I got sober through church, I'm telling everyone church is what you got to do, right? Or 12 step or whatever it might be. Different strokes for different folks. We know that now, but I just still want to call that out, right? There's lots of different paths to recovery. And I'm pleased to say that treatment matching makes it possible for us to find the best optimal way for the folks that we're working with. So, treatment matching, why do we do it? Well, when we do it and we do it right, we get better treatment outcomes. We're going to have better engagement and retention. We're going to save costs on like emergency room visits or redundant people cycling in and out of the wrong level of care. And we also reduce relapse rates. So when we do treatment matching right, it works. So what does that have to do with ASAM? Well, ASAM, we talk about it in different ways. It is a tool to do different things. Some folks are really relying on ASAM criteria for screening purposes. So for example, if I'm calling a, Rorik's treatment center and I want to come in, they can screen me on the phone to determine maybe if I'm going to have withdrawal symptoms when I get there. I'm drinking a gallon of vodka a day. I probably need to get some vitals taken and be seen by a doc, right? Versus they want to come to Terry Smith's outpatient. Um, okay, they haven't used for a couple days. Their withdrawal risk seems minimal. Maybe Terry can help. So with screening, it's quick, right? What's a quick and easy way where we can kind of funnel someone to the right place? Assessment, that's where we dig in and kind of come up with a bigger plan. And one thing I've seen treatment centers do in the past is they kind of do the screening and then the assessment follows, days later. Or they spend all this time on an assessment only to find out the person isn't eligible for services, and then they just wasted 2 hours of the person's time in their own, right? So there's a place for screening and assessment, and ASAM can help us with that. So if you go to NIDA's website, there's a bunch of screening tools listed, so they're listed on here. Some of you might be familiar with these. And then there's also on NIDA's website, there's assessment tools. So here's another list of, some commonly used tools in our industry. So you'll have links to all these. I just put them up there just for you to reference. I know it's small. All right. So let's talk a little bit about the impact on reimbursement. So what I will say before we get too deep is version 4 just came out. It's still really new. They only have the adult version. They plan on doing like a criminal justice version, an adolescent version, and some other specialty populations. Most organizations, including insurers, are not using ASAM 4th edition right now. They're still relying on 3rd. So for example, I'll go back one. So the slides that we have with the little human capital symbol on the bottom, part of it's because I'm branding, right? But really, all the slides that have the little H here on the bottom, those are mine. And then all the other slides that are not so awesome and very boring, those are ASAM slides. I can't change ASAM slides, but I did that so you guys could tell the difference. And you'll have access to all ASAM slides as well. So this is the first ASAM slide that I have. And basically they're talking about, like, this is becoming the industry standard. ASAM criteria is being adopted by more and more states, more health plans. It's been heading in that direction, and I anticipate it'll continue that way. So what's that mean for us? Well, a lot of us are concerned about the payers. So this slide right here, I took a couple screenshots from, this is Blue Cross and Magellan, Cigna down here. All the insurers have been using different criteria to determine medical necessity over time. And if you recall, in Colorado, must have been about 4 or 5 years ago, there was legislation about standardizing assessment processes and criteria for residential treatment in particular. So if you want to know what insurance companies are using, you can get that information usually from their website or directly from them, but there isn't a set standard. But I will say ASAM is pretty solid, and if you rely on that, I think it won't guide you the wrong way at all. If you go to ASAM, the American Society of Addiction Medicine website, you'll see they have a bunch of resources. Like they understand that, hey, it's not just a matter of a bunch of docs figuring out what the best possible treatment is. We live in the real world where sometimes the best possible treatment isn't accessible to everybody, right? So how do we get people the best we can with what we have? And so ASAM, I think, has done a real good job of really upping their game and trying to help providers navigate that landscape more than just having great criteria. So there's all kinds of guides and things on there that you can dig into. So shifting gears, where do most near misses or accidents happen in treatment? This is true in traditional medical care, but it's also true in substance use disorder treatment. It's always all about transitions of care where people always get jammed up. And I'm going to make the case today that by using some solid ASAM criteria or other criteria, but today we're talking about ASAM, you can minimize some of this risk in your organization. So how can you improve client care by using something like ASAM? Well, one of my favorite things about ASAM is it standardizes the assessment. Have you ever sat in a room with a couple treatment providers and gotten into a debate about what somebody needs? Um, and how do you navigate that debate? How do you quantify that debate? We're people, it's not black and white. There is no secret sauce. But we can use our collective knowledge to get to a better answer usually. Same thing with treatment planning. If you've ever worked with a team where people got real excited about one specific thing. So one thing I think about is I remember working with a counselor a long time ago, and this counselor was always top of mind was the spouse at home drinking or using, right? Totally important thing to consider. Absolutely, we should talk about it with every case. However, sometimes people get sober in a place where someone else is using. And while I don't recommend that, I have to acknowledge that that's possible. So if we're comprehensive with our treatment planning, we're going to look at all these factors and not necessarily weigh one over the other. So that kind of helps put our biases in check. Same thing with transitions of care. Using ASAM criteria to help us look at and evaluate somebody helps us kind of make a case for why it's important to transition to whatever the level of care is. We used to have some big fights in an organization I worked with around um, discharge recommendations or continuing care recommendations. So it would go like this. This was a full continuum of care, but a residential facility, we'd have someone in, we'd tell them, hey, we think you need IOP or PHP or partial. Um, and typically, clients weren't real excited to do a lot more treatment. A lot of times they just wanted to go home and do their thing. They don't want to go somewhere 3 nights a week or 5 days a week or whatever it might be. That's absolutely understandable. However, we got to give them the logic behind it. We got to talk them through it. And so one thing I did with this organization is I got our physicians to all agree to present their continuing care recommendations using ASAM criteria, going through the domains that we'll get through in a minute. So I kind of spoke a little bit about this before with the treatment matching. The documentation and communication for those of you organizations that have people transitioning levels of care, a lot of times someone else is talking to the payer or the insurance company. It's not necessarily the provider. And what does that person go off of? They go off the notes. And if you don't have good documentation in your chart, if you're not addressing all the necessary areas, it makes it real hard for the person doing utilization review to communicate that to the payer, to the insurance company. So that's just one reason why using standard criteria can be helpful. All right, here's my warning, my disclaimer, right? So we're going to do the ASAM slides. I warned you, they're real dry. They're white. There's nothing really sexy about them. Really good information in there, made by doctors, so we'll give them a break. If you'd like to access these slides on the left-hand side here, this is the disclaimer that you're going to have to sign and acknowledge. And then this is the actual link, so you guys will be able to go to that link and then you'll sign the disclaimer and they'll send them to you. For fun, when I do things like this, sometimes I'll I'll mess around with AI or ChatGPT and I'll ask them a question. And this is the question: why is ASAM criteria important? When I asked that initially, I got like a 3-page dissertation. So I specified one sentence, right? And so I'll read it because it's kind of small. ASAM criteria are important because they provide standard guidelines for assessing and matching the appropriate level of addiction treatment to individuals' needs, ensuring effective and tailored care. AI generated that. I agree with it. I think you will too as we dig in. All right. Disclaimers, you can read these later, but the important thing is this is not a substitute for clinical judgment. ASAM wants us to know that, right? You got to use your head. It's not just a checkbox thing. Also, don't be stealing their stuff. It's all copyrighted, so you know. I didn't edit any of their slides. I'm presenting them just as they shared with me. And there's 318 of them, by the way. We're not going to do 318 today. Okay. So as I mentioned before in the previous slide, right, this is like the most widely used comprehensive set of standards, right? ASAM is good. ASAM's been around for a while, and these are the four, I'm sorry, these are the 4 volumes, but this is the 4th edition that we're talking about today. That 3rd edition that came out in 2013, this is what most people are using currently. Nothing wrong with that. It's better than using nothing. But as we all learn more about how to apply the 4th edition, I think we're going to see that'll be the new standard. So what's the purpose, right? We saw what ChatGPT said the purpose of ASAM criteria is. But essentially, this word that keeps coming up, individualized and holistic. In an ideal world, that's what we're doing, right? We're treating everybody like they're different. And we're making good, objective decisions about, who we admit and where we transfer them to. The other thing that's really nice about ASAM is it really assesses a bunch of different categories, and we'll get into those categories and what they are, but it helps us figure out how to match the needs to the category. Guiding principles of ASAM, some things that I'll point out. Co-occurring conditions are the expectation, not the exception. That's not new. We've been talking about that since the 90s. I was there. And but what this is saying is we're not going to have like a special carve out unit where you do your substance use treatment here and your mental health treatment there. They have to be delivered at the same time. Not to say there's not a need for places that specialize in each, but most folks that are going to enter treatment are going to have both. And it's not convenient or best practice to really parse those out. They overlap. Also, this notion about care being interdisciplinary, evidence-based, and patient-centered, delivered from a place of empathy. I don't know about you, but when I think about a hospital, I don't really think empathy. I'm not judging hospitals, right? But like people don't think, man, I'm going to go to the ED to get some empathy, right? You're not going to the ED to get some empathy. But they try to provide empathy at the ED, but that's just not what that level of care is known for, right? So if we're approaching treatment with empathy all the way around, that's a little different. And this is where I think the docs at ASAM are saying, this includes us in medicine. We all have to have a good bedside manner. All right, so ASAM assessments, right? So we talked a little bit before about screening and assessment and the difference between the two. ASAM doesn't have a screening book that they publish that, boom, this is the ASAM screening book. That's not to say you can't use the principles and develop your own. Same thing with their level of care assessment, treatment planning. They do have things that you can use, and I'll show you what they look like, but you can make your own based upon the criteria. And so here, this is what we've been waiting for. Here are the criteria. So 4th edition, these are the new domains that we're talking about. So first domain, intoxication and withdrawal. What's different in here is they talk about addiction medications, and I'll dig into that. I'll dig into all these as we go through them. But just a brief overview, biomedical, right? So like what's going on with me that impacts my treatment? Am I using a wheelchair? If so, I might not be able to go to the cool mountain program, right? Pregnancy, that's an issue, right? Those are biomedical conditions that can impact someone's ability to access and participation in treatment. Psychiatric and cognitive conditions, right? We all know what those are. So this is where it gets changed up a little bit more, the substance use related risks, recovery environment interactions, and then the brand new one, number 6, is person-centered consideration. So I'll go through what all of those mean, how they understand them. So within each of those domains, there's different dimensions, right? And so these are a list of some of the dimensions within those domains to give you an idea. Number 6, the newest domain, patient-centered considerations, they're saying it's so important that we partner with people, right? That we use motivational interviewing, that we really need to consider this dimension 6. And these are some of the specific things that we have to look at. How many times have you heard of someone saying, if you don't admit to 30 days of treatment, you're going to die? Probably not as much as they used to, but like we used to talk like that a lot. And sometimes they do die. This is super serious, right? But like, do I really have the ability to say that? If I did a full assessment on you, what do I know about you to tell you that you're going to die? Because maybe I used a certain kind of way, right? Barriers to care. The populations that I think get disproportionately affected the most are mothers, who typically are doing the caregiving, right? When we're saying you got to go to treatment, who's going to watch my kids? And that didn't really fit into my boxes. It does now, right? Also, folks with lack of access to transportation. Also, folks that have jobs that they work, some kind of hours that just don't match with my treatment program schedule, right? These are all very real considerations that ASAM has said, boom, like we're putting this down. This isn't a side conversation. This is a central part of the conversation. The other domains look pretty similar. What's been taken out of here is, well, actually, I'll just go to the next slide and show you. This is a little flow chart that depicts kind of how they arrived at what they did, right? So the first dimension is pretty much the same, except they're explicitly calling out addiction medications. Like hopefully we're to the point now where the conversation isn't like, oh, I don't know if you should take Vivitrol or no. Like the data says that the medications actually are the number one thing that's going to help somebody stay in treatment at certain levels of care. So we got to consider that. Biomedical still exists. They call out psychiatric in criteria 3 specifically. It was kind of implied, but they decided to call it out. One thing that's fascinating in 4 is they took out this idea of readiness to change. And what they said was, hey, this is incorporated in all of them. Readiness to change could be about my willingness to take a medication, right? Could be about being honest about my biomedical conditions or, whatever it might be. And then where we're beginning to get into the really cool stuff is the recovery living environment. We'll talk a little bit about that with NAR and some of the how they partnered with ASAM to help develop some of these criteria. But there's more of a premium placed on that than was previously. So I just talked a little bit about some of the overview. One of the things that people are really concerned and talking about are 3.3 and 3.2. And essentially the conversation goes something like this. What sometimes we call social detox. There's a concern that, hey, ASAM criteria doesn't really reflect anywhere a place, for social detox. Does that mean we can't do it anymore? How is that going to impact funding? Does it mean it's not valid? I don't have answers to those questions, but those are the conversations. And as we dig a little further, I think you'll get a picture of kind of what's out there. It's one thing to propose something, it's another thing to implement it, right? ASAM has proposed this is the best thing we got, right? Edition 4. How does that work for those of us on this call? I don't know. It might take a little bit of doing, right? I'm kind of reminded of so specifically those of you in Colorado, like recovery residences that wouldn't allow people to do medication-assisted therapy that were funded by government money, right? A bill passed a couple of years ago. Rorik Weaver, thank you, sir. Jen Place, you might have been part of that too. Hopefully you're on the side I'm talking about, but yeah, like it's not, you can't deny somebody access to their medications because it argues with your philosophy, right? And we had to pass a law to do that. Harm reduction also being more a part of the conversation than it was before. Um, that used to be, big book or the highway. I mean, that really was how it was, 20 years ago. And I'm proud to say that that's not the case now, right? We have a more open mind. We have different pathways for people. All right. So another thing about the criteria, continuity. So remember that slide where I showed that 80% of near misses in healthcare are associated with transitioning level of care. There it is, right? Um, ASAM also recognizes that, and they kind of baked that into their criteria and tried to put it together in a way that we can make transitions of care easier. So this is what it looks like. Um, they broke it down into these 4 levels, right? And then within each level, there's these different point 1, point 5, point 2, right? So 2.1, I think, has always been IOP, right? But now partial hospitalization, what is that? Where does that fit in here? They actually don't even use that word anymore. So the word that they're using now are high intensity outpatient treatment. So when we dig in, we'll find a little bit more about these differences in level of care. The differences are reflected in staffing patterns, services provided, in the client or patient's need. Um, sorry, I forgot about all these I got a little fancy. See what I did there? All right, so here's a graphic of kind of level of care assessment, right? The patient screen, they enter into addiction treatment. We do a level of care assessment on them. We go through all those dimensions that we talked about, and boom, we put them into treatment, select the level of care. Hopefully, they stay in this continuum of care, right? And they're going forward. Usually it's a step down. We don't often talk a lot of times about a step up. Um, when I'm working with families, particularly like if someone's entering residential, one of the first conversations I want to have with them, and this sounds crass, so bear with me, but how much money do you have? What I'm asking is, hey, let's plan a course of treatment that might last a year, and let's not spend all our money, on a week of detox, right? Like that wouldn't make sense. And I think it's the responsible, patient-centered thing to do. The same conversation when we're recommending, hey, you're stepping down from a residential program, you really need to go, in sober living and do partial. How much is that going to cost them? Does their insurance cover it? It's stupid to make that recommendation when that's just not realistic for them, right? So that needs to be part of the whole conversation, regardless of what level of care you're in, right? So here's just another graphic displayed a different way, right? And this is where recovery residents made it on the map, right? So we're talking about the idea that recovery residences, sober livings, whatever you want to call it, can be part of the recovery process all throughout. Um, I don't know that it can necessarily for medically managed inpatient, right? Or maybe medically managed residential. But the implication is that recovery residents can go side by side and paired really nicely with these other levels of care, like PHP, IOP, right? Peer coaching. So level 1 outpatient. So here's the dimensions. If you guys remember, there used to be a 0.5 and 0.5. I think they called it like prevention or early education. That was like DUI classes a lot of times. And basically what they said is, hey, substance use disorder is so common and so prevalent that every medical provider should be capable of doing some prevention and screening around that. And they kind of set the standard and said, we don't need this 0.5 anymore. This 0.5 should be delivered in all the other medical settings. So just like when you get your height and weight taken, when you go to get a physical, they should be asking you about substance use disorder. That's not to say that that's happening, but that's saying this is kind of the guidance and the guidance that they suggested for providers. So recovery residents, so they kind of break recovery residences up into Three categories: supervised, monitored, and peer run. If you think about it, right, that's absolutely true. We have recovery residences that might have staff full-time 24/7, right? And we have other things like the Oxford House that's been around forever, right? Super successful, super important. It's peer run. It deserves a mention. That's a great program for some folks, right? Clinically managed outpatient. So now we're getting into some of the services provided, or kind of like the positions, the staffing patterns, right? So this is what ASAM is suggesting. This is not a law. It's not saying this is what you have to do, but they're basically putting the premise that, hey, if you're doing 1.5 outpatient therapy, you probably aren't going to need a medical director. Sure, you could benefit from one, but you don't have to do it, right? Um, Maybe like allied health staff, so I'm thinking about like nursing, right? Like, do you really have nursing at outpatient 1.5 therapy? Some places do, but it's not feasible for a lot of organizations to do that. That's not cost effective. Same thing with like physical exams. Um, One of the first questions I ask people in my personal life when they're having any kind of whatever issue, like mental health related or substance use related, I always ask them when the last time they had a physical was, when the last time they had blood work. Because a lot of times there's things that can happen in us physically that absolutely impact these other areas of life. Guess what? ASAM's got that covered, right? In Dimension 2, biomedical conditions. So when we look at things like a physical exam, it's easy to say, the state wants us to do that for licensing. That's a pain in the ass. We do that with dentistry, right? We all do that with dentistry because we have to. But yeah, in an ideal world, sure, everyone should get a dental checkup really regularly. One of the challenges with doing a really good multidisciplinary assessment is that there's so many things to consider. And if I only have an hour or an hour and a half or 2 hours, how am I going to get through this 17-page assessment? We'll talk a little bit about that in a minute. So here's medically managed. So dimension 1 is outpatient, right? And then we're moving up, and remember, dimension 4 is like medically managed. So as you can see from this slide, it's the same stuff, right? Talks about how frequently or quickly you should have a physical, what staffing should look like. Absolutely, you need to have a physician on staff, for medically managed. Otherwise, it wouldn't be medically managed, right? Who's going to prescribe? Residential, 3.1, 3.5, same thing. You guys can go back and dig through this stuff. Let me take a second and pause and open the chat. Let's see. Emily wants me to call her. I will, Emily. All right, Bria put in something about HICPUF. Awesome. Yep, we talked a little bit about that. Bullets in the back. Okay, Jen, thanks for putting the clarity in there about the 2024 edition, about the black part of the slide up on dimension 6. So just take a sec, guys, throw something in the chat if you want. I'm looking at it right now to see if there's anything I should respond to before we go further. But to Bria's mention about HICPUF. Yeah, HICPUF, so the Colorado Healthcare Policy and Financing doesn't really know how they're going to do this, and they're not alone. We're seeing that with a lot of the other payers as well. I guess to that, what I would say is we didn't think we'd get an IMD waiver a couple years ago, and they swore up and down it wasn't going to happen, and we got an IMD waiver now. I don't know what that looks like. I do know that there's some committees, some folks meeting around the state. I do know that HICPUF sent out a survey to a bunch of providers, I want to say 2 or 3 months ago, on this specific topic. Email me if you're interested, and I'll try and connect you with someone that can connect you with that work group or that committee. All right. So shifting gears, talking about treatment planning assessments. So in an ideal biopsychosocial assessment, we talked about exploring the needs and the different dimensions. Where we fall short a lot of times in medicine, in addiction treatment, in life, like, aren't we good at focusing on the negative? As a therapist, when someone comes to me, like, my first thought isn't like, oh, what's going well in your life that you're coming to see me? Right? It's like, what happened that brought you here, right? And that's important, and we need to ask that stuff, but when we're so focused on that deficit-based stuff, we're missing resilience, we're missing strengths, and that's where recovery really happens, right? So how do we incorporate someone's strengths into assessment and treatment planning? Highly variable. Here's an example of something I did once when I worked for a treatment center. When we would admit a new client, we would send an email out to everyone saying, hey, we admitted Rorik. And Rorik's a 37-year-old blah 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 with alcoholism and this laundry list of all the stuff, all the problems Rorik has. So Rorik gets back to detox and they're like, oh, you're the dude with 17 DUIs. And you know, one of the things we did is I made it so we had to start putting personal, positive, strength-based information in these emails. We still included that other stuff, but by the way, Rorik really likes heavy metal, and he's a kung fu master, and he plays the banjo. So when he's talking to the nurse, um, they talk about that stuff. You're the guy that plays the banjo. Okay, like that's a much better client or patient experience on the front end than you're the dude with 17 DUIs. So that's one subtle example, right? Like you got to do it different for your for every organization, every level of care. So here's another graphic that kind of outlines the treatment planning assessment. There's lots of flow charts in the ASAM slides. Everybody wants to see Rorik's banjo. Well, wait, Rorik, go grab it. Just don't grab the 308 banjo. All right, so let's jump into ASAM tools and resources. So I'm not going to go super duper deep, but I'll give you some things. You will have all these links to be able to access them on your own. The first one I have for you is this is an actual copy of ASAM's clinical assessment intake form. So the link is down there at the bottom of the slide. I think it's like 20 pages long or something. Like it's really long, but it's pretty clear. And I think that you could take it, you could use it, or you could make some modification of it and adopt it and make it fit or work for your organization. I'm obviously not going to show all 8 pages, but the way they do it is they make it so you don't have to do a lot of writing, and sometimes that's helpful. I never loved writing like 10-paragraph narratives of a patient's substance use, right? It was a lot easier for me to check a couple boxes and write a sentence or two. So this is a resource definitely worth referencing. Implementation tool. So if you go to the asamcriteria.org website, bunch of different stuff. So like anything, someone figured out a way to monetize it. And you can spend a bunch of money on, software and handbooks and all these some cool things. Some of them are absolutely worthwhile. Some of them are not so much. Really depends on your organization. I do think they do a really nice job with their stuff. But right now, the implementation tools, I've only seen stuff up to the 3rd edition, right? So this 4th edition criteria we're talking about, like all the other stuff hasn't been developed yet that I've seen. So I expect that that'll be changing and we'll see more of that over time. Here's an implementation guide, right? You can get this one through Change Companies and the National Institute of Addiction Treatment. I can't remember. It's the quality people, the NATAX folks. There's a lot of great resources. Check their website out as well. Many of you have probably seen this, right? So a lot of insurance companies are still looking at the old ASAM crosswalk. So we have our same dimensions, 6 dimensions, but these dimensions mean different things now, right? The first 3 are pretty much the same, but 4, 5, and 6 are a little different. And the way it used to work, right, is I would assess somebody's withdrawal potential in dimension 1, and I would figure out what box they fit in, and boom, let's say they fit into 3.1. I do the same thing for each category, and then at the end I would have a picture as to kind of what the needs are. And it's not like a math problem where you just add up the score and then you're like, okay, you have a score of 12, so clearly you need IOP. but it is a graphical reference that makes sense to people. I have used this with patients in the past, especially when we're talking about making continuing care recommendations, right? I don't want to go to partial. I don't need it. I need to get back to my job. Okay, cool. Like I appreciate that. I hear you. Let me show you why I said that, and maybe it'll make more sense. And so for some people, they're visual. You show them something like this, or maybe you have them rate themselves. ASAM doesn't recommend that, and um, it's probably not best practice, right? But sometimes you got to get creative when you're up against a brick wall. And we work with some tough patients sometimes, right? So you should have as many tools in your toolbox as you can. Another resource, if you go to ASAM's actual website, um, they have a bunch of stuff. So I showed you guys some of the insurance coverage stuff that they had before. I'm not gonna like show their website, but when you look at the top, all these different boxes, a lot of this stuff is free. It's stuff that you can access and use. Some of it's links to some paid stuff. ASAM, I'm not currently an ASAM member. I have been a allied member, so you don't have to be a doctor to be part of ASAM. I was an allied member. It was a cool membership. Cost a couple bucks though, so I didn't renew it. The ASAM National ASAM conference will actually be here in Denver next year. If you get a chance to go, super cool conference. It's the coolest medical conference you can go to. Because when you think about a lot of our addiction medicine docs, a lot of them have lived experience. It's not like you're hanging out with a bunch of surgeons that are real dry and stuffy and analytical. Like I find that most addiction medicine docs have a pretty good bedside manner. They're used to dealing with some insanity, and they can hang. Okay, so I'm looking at, that's actually the last slide. So there's my contact information and all that fun stuff. We'll shift gears and jump into questions. Jen Place put a question up. Didn't see it on the slide, but she said that she's assuming, I'm assuming.
I was answering Terry's question about OTP.
Thank you, Jen. What do you want to elaborate?
No, Terry had just asked if OTP, I think it was on one of your slides, I didn't see it, if it meant outpatient. And I said, I believe it references opioid treatment programs, so methadone clinics.
I'm with that. You are correct. And that terminology is changing as well, right? This whole idea of like medication assisted therapy versus medication therapy. We're trying to figure out how to refer to things in non-biased ways, not just in addiction treatment, right? I mean, we call it substance use disorder now, right? So I said addiction treatment. It's not, it's substance use disorder treatment, but it takes a while to, come around with our language and get aligned. Someone will probably form a committee on why we got to keep an addiction treatment. I don't know. I got more important battles to fight, right? But if calling it substance use disorder treatment gets more people in it, I'll call it that. I still call myself an addict, not a person living in long-term recovery with. I'm an addict, but teach their own, right? All right. So that's the conclusion of the presentation. Why don't we open up for questions either in the chat box or we can just call them out. And if you're annoying, Bria will mute you. So keep it brief.
It's true. I totally will. Looks like Jennifer has her hand up.
Please, Jen.
Thanks, Bria. Thanks, Jay. I was really curious about kind of a crosswalk, and it sounds like they've not yet developed a non-software based crosswalk for folks for placement criteria. Is that correct?
I have not seen one, Jen. I think you're probably right. The crosswalk that I shared before on the screen, I'll go back to it. One of the problems with that is people were not using it the way it was intended. They were doing something similar to what I did. Is like, hey, let's give the patient a highlighted marker and let them take a look at it and see if they can figure out, what aligns with them, right? It's not what it was intended for, but people were doing that. They were adding up numbers when they shouldn't have. it is easier, I suppose, to probably have like an algorithm, and I don't know if it'll be capable of doing that, but like we're people. AI's come a long way, but I've yet to see, medical decision making been like entirely trusted on an algorithm. Um, I guess that's my it's what I like and what I don't like about ASAM, right? Like this is helpful. I like this, but it's not that usable. The ASAM slides that they sent me 317 slides, right? Like, so I took out a lot of the slides. Like they're not usable to the average person. That's why we got to take the principles and ideas and figure out a way to adapt them for us. But Jen, maybe you and I can get rich and come up with a cool algorithm. I've tried it before. It's a lot harder than it thinks. So I'm not bashing ASAM at all. Best game in town and a lot of work to do.
They've got a decent one for um, the third edition that was used by clinicians, different than what you showed. But since I'm teaching master's level clinicians, I need something, and I'm not encouraging them, oh, just purchase the software and punch the numbers and figure it out. No, I want them to be able to see it and know, okay, if they're a 2 or 3 on dimension 3, and these kind of the algorithms, that's what I'm looking for and hoping someone comes up with, versus just pay for the software, because not everyone can do that.
Bet you Rob Ballard can do it. Let's take him to lunch. Who else, folks? We absolutely can end early. We don't need to, take a bio break and everything. Bria, you got a question, please.
Yeah, I got one. So you mentioned in the very beginning that the ASAM was not supposed to take the place of clinical expertise, I think is how you said that.
Yeah.
So can we talk about how that's true until we get to funding those things? Because I know that, as addiction specialists, substance use disorder providers, that we know that our expertise sometimes does not align with the ASAM. But in order to receive your Medicaid funds, you have to align with ASAM.
Yeah. Muted. Next question. No, I'm kidding. Yeah, Bria, you're spot on. Like we all have that. And one of the things that I appreciate about ASAM is it gives us a framework that makes it easier for us to articulate why we believe what we believe in terms of placement, right? So if I say Terry needs rehab because clearly on dimension 4 she's a whatever, right? If dimension 4 involves a number, her blood pressure is this, her weight is that, her it's easier. If I say Terry doesn't have a good recovery environment, that's different than saying Terry lives in a neighborhood that's known for substance use. There's 3 people in the household that are actively using. It's that guide, it's that framework that helps me strengthen my case. But just like any insurance for any issue, right? Like most of them like to deny without even looking at your claim, right? And then you gotta fight the fight and get through it, right? They try and make it cumbersome. So I think we're likely to always experience something like that. But if we want to be really good providers, we got to play the game. We got to be good at being able to articulate our case to the patient, to our coworkers, to the insurance company, right? You see the common thread? Other questions? Thanks, Bria. We can wrap it up, folks. Really
Jake,
appreciate it. Oh, go ahead.
Sorry to interrupt. I kind of have a related question to what Bria was asking. Do we know, is there kind of like a set date or time in which insurance companies are saying, hey, yeah, we're only looking at 4th edition, or has that already happened? I know like when they switched ICD codes, from 9 to 10, it was like, that's taking place on this particular date, and folks had to really shift their method of operation at that time. Is the same thing projected to happen with the new ASAM?
That's a great question, Jen. I do not definitively know the answer to that. What I suspect is each company has autonomy to make changes and adopt things as they will. I believe the way the laws are written, they probably have to give a, 90-day notice or something like that, which will probably be on the small print at the bottom of their website that no one will be able to find, right? Or maybe they're sending it out to all the providers, right? Like that would be kind of cool. But yeah, I don't definitively know that. I do imagine that it varies by state. Right, we have our federal laws, but we also have state laws about how insurance is administered. So absolutely, I think there would be variability based on that. Bria, give me another softball.
All right, it's not a question, it's a follow-up to Jen's question. So I know that from the HICPA standpoint, so the Medicaid standpoint and the ASAM level change, is that they were talking about wanting to address the withdrawal management 3.5, 3.2 question before they started doing those contracts around the RAY funding, so funding distribution from that Medicaid perspective. Like they really want to get to the bottom of that 3.2, 3.5 situation before they make that a requirement. And another thing too would be they wrote that bill this year, Jen, you remember, about making funding available for partial hospitalization, which is another part of that ASAM criteria. So I think that at least in terms of Medicaid, we are not going to see a requirement until those two things are managed.
Awesome. Thanks, Bria. You should head our state association of treatment providers. Oh yeah, you do that. Yeah, thanks. Shout out to Copa. Thanks for sponsoring this and putting this on. Really appreciate it, Copa.
Yeah, I've actually learned quite a bit today, Jay. And had I had some of those handouts 3 years ago, you would be looking at a much more comprehensively knowledgeable human here. So thank you for coming.
You bet. Anyone else? Last chance. Cool. Well, thank you, everybody. Let me turn it back over to you, Sydney.
Yeah, thanks so much, everybody, for showing up. Like I said, I'll have the recording and the slides for y'all at some point within the next week. And if you ever have any questions, I'll make sure that you have Jay's email address too, so you can connect with him if you have any additional questions about ASAM. Thanks so much for showing up, everybody. Have a great day.